Thank you for viewing the CHDP Code Conversion webinar. My name is Melissa Kelly Ortega. I am the Provider Services Training Specialist at Central California Alliance for Health. This webinar, the PDF PowerPoint, a frequently asked questions document, and other valuable resources can be found on the Alliance website provider page under Provider Workshops. Allow me to introduce Ashley Pickerill, Coding Resource Specialist at Central California Alliance for Health. Good afternoon, Ashley.
Good afternoon, Melissa, and thank you everybody for joining us for today's webinar. We are here to talk about the transition of billing for services covered under the Child Health and Disability Program, also known as CHDP. For the past 20 years or so, CHDP claims have required their own unique form known as the PM160. California Department of Healthcare Services, or DHCS, made the decision to transition the billing requirements for all CHDP claims to conform to HIPAA standards. During this presentation, we will discuss how this transition will affect you, how your office will need to submit claims in order to receive correct reimbursement and CBI credit, as well as documentation and coding requirements. We hope this is good news, as providers will now have one less claim form to fill out and only one set of codes. Items that we will cover today are: what is CHDP? What is the CHDP transition and the new requirements? We will review the well-child visit guidelines in accordance to the AAP and Bright Futures periodicity schedule. We'll touch base on CHDP reimbursement, and we'll go over some coding and claims recommendations. By the end of this webinar, I hope you are able to understand the new claims reporting requirements, understand the proper codes to use when reporting services, and understand the impact on CBI and capitation visit requirements. First, let's go over some history of CHDP and why we have this program. What is CHDP? The CHDP program was implemented in 1973, originally to meet federal Medicaid early and periodic screening mandates in California. Over the years, the program has expanded to all low-income children and youth in California to assure they have access to preventive care. The program is financed by the state's General Fund and Tobacco Settlement Fund. Approximately 1.1 million children and youth receive preventive services, and over 2 million receive immunizations per year. The Gateway program came into effect early July 2003 to maximize enrollment of uninsured children and youth in the Medi-Cal program. CHDP benefits are for preventive health services and do not include any diagnostic or treatment services. Now, let's discuss what is changing with CHDP services. The program's billing requirements are moving from state and local codes to the national CPT HIPAA codes for all CHDP services performed on or after January 1st, 2018. All claims will now be billed on the CMS 1500 or UB04 claim forms or their electronic equivalent. The PM160 and the eCHDP claim forms will no longer be used for dates of service on or after January 1st, 2018. CHDP claims may be submitted through MedImpact until March 31st, 2018, and we will discuss this later in our presentation for more information. Providers are still required to obtain their CHDP certification in order to bill for these services. Some of you may be wondering why DHCS is making this change. The answer is HIPAA. HIPAA requires conformity to national standards for electronic healthcare transactions, for example, getting rid of the PM160, as well as use of national standard code sets, which is why we're using the national CPT codes instead of the state and local codes. This transition is being done in two phases. The first phase is for all laboratory claims billed by lab providers, and this became effective as of February 1st, 2017. Phase 2 is for provider CHDP claims, which is effective January 1st, 2018. Keep in mind, it is the date of service that determines which claim form is being used. As I mentioned, Phase 1 has already been implemented, and we are currently moving into Phase 2. This is where all of our primary care providers are affected. Phase 2 includes all primary care services, all primary care CHDP services, for example, the health assessments, immunizations, and any in-office labs that were performed. All CHDP services performed on or after January 1st, 2018 will be billed on the CMS 1500 or the UB04 claim forms, or their electronic equivalent. For any CHDP claims performed prior to January 1st, they need to be submitted on a PM 160 regardless of when the claim is submitted. Again, this is keeping in mind that it is the date of service that determines the claim form. The CMS 1500 and the UB04 claim forms do not have fields for all of the PM 160 required information, nor will either of these forms be modified to include fields for this information. The question many have is, how do we relay the information back to the providers and to the county? Currently, DHCS will not be requiring any of this information to be entered on the claims. However, providers are required to document the information in the patient's medical record. Another thing to note, although providers are no longer required to submit a copy of the health assessment to the county, it is still best practice to provide the patient with an after-visit summary. CHDP health assessments should be completed in accordance to the CHDP health assessment requirements and the Bright Futures periodicity schedule. The CHDP health assessment requirements are very similar to those recommended by Bright Futures, but do differ slightly. A complete list of requirements can be found on the CHDP provider manual on the Medi-Cal website. Based on the CHDP health assessment guidelines, each exam should have an age and gender appropriate, history and physical, nutritional assessment, developmental and behavioral screening, anticipatory guidance, just to name a few. You can view the complete list of requirements on the Medi-Cal website underneath the CHDP provider manual. A link to this resource is included in the resource document as well as at the end of this presentation. A complete health assessment, also known as a preventive visit, should include an age-appropriate history, exam, and anticipatory guidance, which is recommended at every visit on the American Academy of Pediatrics schedule. A complete health assessment includes vitals, height, weight, head circumference, blood pressure, BMI. And although it is not required to report the member's BMI via diagnosis code, the Alliance does ask that providers do utilize the appropriate BMI ICD-10 codes on the claim forms. Knowing the member's BMI helps the Alliance and the counties identify those members who may qualify for additional resources. A list of the BMI ICD-10 codes can be found on the CHDP resource document that it will be uploaded to our website shortly. Getting back to the guidelines, you also need a complete history with review of systems, past family and social history, complete age-appropriate, unclothed or draped exam, nutritional and physical activity assessment and guidance. Providers may use the medically necessary interperiodic health assessments for necessary assessments that fall outside of the periodicity schedule, such as school exams, sports exams, a camp physical, or foster care or out-of-home placement. Additional assessments that should be performed are the sensory screenings. Vision screenings are recommended at ages 3, 5, 8, 12, and 16. While the vision screening is typically included in the preventative exam, the Alliance is looking at making CPT code 99173 a benefit. More information will be coming soon with this. Health screenings, hearing screenings, which are separately reimbursable when performed. You may bill those with CPT code 92551. Developmental screenings are not required by the CHDP, but are recommended by the American Academy of Pediatrics. Developmental screenings are included in the preventive visits. They are typically recommended at months 9, 18, and 30. The MCHAT, or the Autism Spectrum Disorder Screening, is typically recommended at months 18 and 24. Providers may bill CPT code 96110 when scoring and report are performed. Some examples of appropriate developmental screening tools include, but are not limited to, the ASQ forms, the MCHAT, the Child Development Inventory, as well as the Denver Developmental Screening Test. Psychosocial and behavioral assessments are required by CHDP. This service is included in the preventive visits unless scoring and documentation performed using a standardized instrument. They are required at all periodic well-child visits, and it does include an assessment for child social, emotional health, caregiver depression, child-adolescent depression, as well as ADHD. Complete immunizations on schedule as recommended by the CDC. The immunization schedule for children ages 0 through 6 years old are shown here. You want to make sure you bill for the immunizations using the appropriate national CPT code. Also, update the immunization registries, both CARE and or RIDE, whichever is resided in your county, and make sure to bill the immunizations appropriately to increase not only to increase your CBI payment for the CIS measure. And here is the immunization schedule for children ages 7 through 18 years of age. And again, make sure you're billing with the appropriate CPT code for correct reimbursement as well as CBI credits, and also update the immunization registries. Now let's talk about the tuberculosis risk assessment. TB risk assessments should be performed on members at months 1, 6, and 12, and annually thereafter. The risk assessment is included in the preventive exam and should not be billed separately. If a new risk is identified, latent tuberculosis infection testing is recommended. When latent tuberculosis infection testing is indicated, the clinician may perform a tuberculin skin test or draw an interferon release assay depending on the child's birthplace and age. Here is a tool used to identify asymptomatic children who should be tested for the latent tuberculosis infection testing. Retesting should only be done in members who previously tested negative and have new risk factors since the last assessment. A link for these guidelines is listed on the resource slide at the end of the presentation, as well as in the resource document. Providers should avoid testing persons who are at low risk for TB, as a decision to test is a decision to treat. Keep in mind, a negative test for latent TB infection does not rule out active TB. For children with TB symptoms or an abnormal chest X-ray that is consistent with active TB disease, make sure to evaluate the member for active TB disease. Do not treat for latent tuberculosis until active TB has been excluded. Just as a quick note, evaluate for active TB disease with a chest X-ray, symptom screen, and if indicated, a sputum AFB smears, cultures, and nucleic acid amplification testing. A negative tuberculin skin test or interferon gamma release assay does not rule out active TB. Providers should also perform risk assessments or screenings as appropriate based on the universal screening requirements for patients with Medicaid in high prevalence areas, including labs and oral health. Some of the screening labs include anemia, lead, dyslipidemia, and STD and HIV testing. Providers should assess whether a patient has a dental home and sees a dentist regularly. Referral for a dental home at the sign of a first tooth or first birthday, whichever comes first. Refer patients every 6 months for routine dental care. Primary care providers should also provide a fluoride varnish in a primary care setting every 3 to 6 months once the first tooth comes in. Providers in the primary care setting may report CPT code 99188 for reimbursement of the fluoride varnish. Now let's talk about the chdp reimbursement. The Alliance is adopting the current Medi-Cal rates. Contracted chdp certified providers will continue to receive 200% of the Medi-Cal rates as per our contract. Should providers have any questions regarding the chdp rate reimbursement, please contact your provider services representative. All claims must be submitted with the appropriate CPT and HCPCS codes as well as ICD-10 codes. Without the proper CPT or ICD-10 codes, claims will be denied. Providers may review the full chdp crosswalk on the Medi-Cal website. This slide has a demonstration of the most common chdp to CPT codes in the conversion list. Again, the link for the full conversion list is located at the end of this presentation and on the resource document. You can also find this on the Medi-Cal website underneath the chdp transition information. For services performed on or after January 1st, 2018, we recommend you submit claims electronically instead via paper as it speeds up the payment process. As you wrap up your 2017 chdp billing, we are allowing providers 3 months to submit their electronic PM160 claims. After March 31st, 2018, all claims must be submitted via hard copy for chdp claims prior to January 1st, 2018. For example, if you have a claim for a date of service of December 18th, 2017, you have until March 31st, 2018 to submit the claim through electronically using eChdp. If the claim were to be submitted on April 1st, 2018, you would need to submit that claim via paper PM160. Remember, it is the date of service that determines which claim form is used. Per DHCS requirements, all chdp providers must be enrolled in the Vaccines for Children program. Medi-Cal does not reimburse the cost of provider purchased vaccines that are available free from other sources, including VSC. Members 18 years and younger still have their immunizations at their PCP or be referred to a pharmacy or another primary care provider. The Alliance will reimburse for vaccine administration costs only. Let's take a look at an example of what a CMS 1500 claim form would look like. This is for a 5-year-old well-child health assessment. We have the health assessment, which was previously billed with chdp code 01, that is now billed with CPT code 99393. The hearing assessment, which is previously billed with 07, is now billed with CPT code 92551. We have the MMR vaccine that was previously billed with CHDP code 74, is now billed with 90710. And we also have the DTaP and the polio vaccine, previously billed with CHDP code 83, now billed with 90696. You will notice that modifier SL is being used on each CPT code to indicate that the vaccines were part of the VSC stock. Now let's look at what a claim form would look like for a UB04 claim. This is for an 11-year-old well-child assessment. We have the health assessment, which is previously billed with CHDP code 01, now being billed with 99393. The meningococcal vaccine was previously billed with CHDP code M5, is now billed with CPT code 90621. The HPV vaccine, previously billed with CHDP code 94, is now billed with CPT code 90651. Note, both vaccines do have the modifier SL to indicate that they are part of the VSC stock. If you need any type of claims help, please contact our claims adjudicators. They are available from Monday through Friday from 9 a.m. to 4 p.m. to answer any questions and help you solve any problems. You can contact our claims department at 1-800-700-3874, extension 5503. Now let's talk about some of the measures that are being affected for CBI. The initial health assessments, as well as the well adolescent and well child visits. You do want to make sure you are billing with the correct preventive service codes to ensure that you're getting credit for these 3 measures. And the childhood immunization status, or the CIS measure, you want to make sure you're billing with the correct vaccines codes and keep the registries updated to ensure full credit for these. Providers will still be paid fee-for-service for all CHDP services. These claims will be excluded from the capitation monitoring data extract. If you have any additional questions on reimbursement, please contact your provider services representative. Here you can find contact information for our county partners as well as our eCHDP vendor. This information is also included on the resource document. As you saw some links throughout the presentation, here they are again. They are also located on the resource document. This has concluded our presentation for today. I would like you for taking the time to join us. I hope the information was helpful and you'll be able to put to use in your offices. For now, I will turn it over to Melissa.
Thank you, Ashley. The Alliance will keep providers up to date on any other changes via fax and email blast. If viewers still have questions, they can contact the Provider Services representative at 1-800-700-3874, extension 5504. On behalf of Central California Alliance for Health and our presenter, thank you for viewing the CHDP Code Conversion webinar.